IFIS really is a progressive meiosis intraoperatively, and that naturally increases the chance of posterior capsule rupture, vitreous loss. The unique complication of IFIS, though, comes from the iris prolapse and the fact that once the iris prolapses to the phaco incision and you start moving the tip around, you try to reposit it, it gets thinner, it gets more macerated, and if you end up with large sectoral defects in the iris stroma, that can be very, very hard to correct. And so avoiding that prolapse is key. The most important thing in advance is to try to anticipate, are you going to have mild IFIS or severe IFIS? And the best indicator is the pupil dilation. So if you have a patient on an alpha blocker, the pupil dilates well preoperatively, then usually even if they're on tamsulosin, all you need is an intracameral phenylephrine to increase the iris tone. But if the pupil doesn't dilate well, then you have to start thinking about mechanical devices like a ring or iris retractors, because they're best placed before the capsulotomy. They're much harder to place once you've already completed the capsulorhexis. So intraoperatively, I still like using iris retractors. A lot of people will like a pupil expansion ring. There are many different varieties now, and they all work because basically there's no way the pupil can constrict. It's important, though, to do them early, because once you have iris prolapse and it gets macerated, part of the tissue wants to fly into the incision, fly into the phaco tip. The other thing is to not overfill with the viscoelastic, because the iris doesn't have its normal stiffness. It does tend to prolapse more easily. So you need enough, but not too much, or you may actually cause the iris prolapse with too much OVD.